esteemed chairpersons, fellow delegates, I'm going to share with you some of the experience which is available, but device-based autonomic modulation. And I think the neuromodulation in heart failure is becoming an important aspect. Heart failure is associated with significant perturbances of autonomic sort of abnormality or irregulation, predominant sympathetic activation over parasympathetic system. Indirectly, this results in indirect markers of cardiac vagal tone like heart rate variability, heart rate turbulence, baroreflex sensitivity. They're all suppressed in cardiac failure, and usually they also then result in worse outcome. So anything which can probably alter this regulation may be helpful in patient with heart failure. And this is what we know, that increase in cardiac vagal tone, pharmacological beta receptor blockade associated with the improved functional status and survival of heart failure patients. So I think there is some, so this is a patients who are not benefited by drugs, probably can there be other alternatives like electrical stimulation to have some beneficial effects. The deleterious effect of sympathetic overactivity in hypertension, I think we all, like tachycardia has been already, the heart rate has been adequately addressed by Professor Rame, that these are and maybe other alterations which also occurs with oversympathetic activity as such. So autonomic dysfunction occurs in heart failure and is characterized by enhanced sympathetic activity and withdrawal of parasympathetic control. Autonomic imbalance, important mediator of increased mortality and morbidity in both MI and heart failure. And this has been also like this CBIS-2 trial, diminished vagal activity and increased heart rate are predictors of high mortality. The cardiac vagal tone is controlled by preganglionic parasympathetic cardiac neurons and resides mainly in nucleus in the brainstem region. Parasympathetic cardiac afferent neurons in nucleus ambiguous, intrinsically electrically silent, need presynaptic input to generate and modulate parasympathetic afferent activity and tone. So I think as far as these reflexes, whether from the baroreceptors or the spinal cord, they all, when these influences go to the brainstem region, this result in decrease in sympathetic activity and also indirectly also further raise the parasympathetic activity. The presynaptic input is provided by sensory arterial baroreceptor, respiratory sensory neuron, or spinal cord afferent fibers. Now there are four approaches, I think, which are being evaluated, that how you can increase the vagal tone. One is afferent vagal stimulation, whether you do by cervical vagal nerve stimulation or intracardiac vagal stimulation. And the other is reflex activation of parasympathetic tone and sympathetic inhibition by afferent fiber stimulation. And there are two modalities which are being tried. One is spinal cord stimulation and another is carotid sinus nerve stimulation. So these are the ways that electrical approaches have been used, that how we can try to increase the vagal tone in the body and which may have a beneficial effect in heart failure. Spinal cord stimulation, I think this is has been used for chronic intractable pain, refractory angina, even sometimes in peripheral vascular disease or Raynaud's phenomena. And I think more than 50,000 stimulators are implanted mainly in patients with intractable angina and with no other options. It does improve the ischemia, and that's probably the reason that I think patients may get, it has limited impact on coronary blood flow, therefore the mechanism lies somewhere else. But if we look at it also improves the LV function, reduces ventricular arrhythmia, associated with better invasive hemodynamic evaluation in patients with normal LV function, reduce risk of ventricular arrhythmia in animals, models of heart failure, and improve LV function in animal models. So these are, I think, probably leads that this particular approach may help some of the patients with heart failure, where other modalities are not helpful. And that spinal cord stimulation, that I think it's usually the neurosurgical colleagues try to do the procedure. So you introduce into these direct to the epidural space, and that will be, and then I think you can position the electrode depending upon where you want to place it. There are not, there are these tools that I could lay my hand, that is sinus, spinal cord stimulation, heart safety and feasibility study, which is, I think, 20 patients with LV ejection fraction 20-35%, and class 3, and all also at ICD is being sort of looked at. And defeat heart failure is a randomized study, 250 patients with the low ejection fraction class 3 with ICD and spinal cord stimulation on and off. So this is the protocol. I think this study could, as far as the data which is available, this modality I think is under evaluation, whether it will, though it has been sort of used in chronic severe angina patient, but in heart failure, how does it translate into, I think only the time will tell us. The baroreceptor stimulation, I think this was again basically initially has been used in hypertension, resistant hypertension, that this modality may be helpful. And the baroreceptors are embedded in the arterial walls, preferentially found in the aortic arch at the origin of varicoccephalic or left subclavian artery, varicoccephalic artery at its bifurcation into right subclavian and right common carotid, in the carotid sinus, and that is the area which is mostly has been used for stimulation, and along with common carotid arteries. Now this is the carotid sinus area which is has these baroreceptors and the stimulation, and then I think the effects both decrease in sympathetic or parasympathetic, and effect on different heart, kidney, vessels, and there is this device was, this approach was mainly evaluated for resistant hypertension, and there are experiences available, though not very encouraging. If you look at the physiology of carotid baroreceptors, carotid baroreflex circuit represents the main part of the arterial baroreflex system. Carotid baroreceptors are stretch-sensitive mechanosensors located at the right and left carotid sinus. They sense the distension of the carotid wall and transmit signals to the brainstem by the glossopharyngeal vagus nerve. In addition to regulating sympathetic outflow, baroreceptors then relate the traffic ascends the carotid sinus nerve to the nucleus ambiguous, and then which controls the vagal parasympathetic activity and vagal motor nucleus to modulate parasympathetic effect traffic to the heart and also other organ to the vagus nerve. Theoretically, unlike pharmacological therapies that act in a non-specific manner regarding target organ effects, stimulating the baroreflex with baroreceptor-activated therapy alters release of transmitters in region-specific and regulator proportions by means such as frequency coding. I think by different kind of strength you probably may be able to stimulate different fibers in the vagus nerve. The hypertension management, arterial vasodilatation, reduced central, I think that probably the reason that this was evaluated in patients with resistant hypertension, heart rate control, restored sympathovagal imbalance, the vagal balance, and arrhythmia suppression, inhibition of sympathetic nervous and renin-angiotensin aldosterone system, renal nerve mediation, inhibition of renal secretion, renal artery vasodilatation, reduced renal artery stiffness, reduced plasma non-evaporating. And it also has effect on the other like venous congestion, LV filling pressure, reduced venous neural tone leading to increased venous capacitance, and reduced proximal tubular sodium and so the reabsorption, suppressed non-osmotic release of vasopressin, myocardial ischemia, coronary artery vasodilatation, LV hypertrophy regression, reduced heart rate and pressure volume area. Exercise reduced muscle sympathetic nerve activity, even it also has effect on the pulmonary vasculature, decreased pulmonary vascular resistance, pulmonary artery stiffness, and also has some role in obstructive sleep apnea. So these are the various mechanisms that baroreceptor stimulation may be helpful. Now, if you denervate the carotid sinus area, unilateral abolishment of the baroreflex through carotid sinus anesthesia cause 10 to 40 millimeter increase. But if you do on the both sides, there is a huge rise in pressure, because that the vagal tone probably may be totally going, and that may be resulting in higher sympathetic activity. So baroreceptor stimulation effects respond to changes increase as the baroreceptor activation powerfully contributes to baseline parasympathetic tone, and that is, I think, by these modalities we are trying to increase parasympathetic tone, and the baroreflex is profoundly inhibited in heart failure patients. Electrical stimulation of afferent carotid sinus nerves may increase vagal tone during heart failure. The decrease of heart rate and blood pressure by a parasympathetic afferent action and sympathetic withdrawal by a chronic low-intensity carotid sinus stimulation lowers blood pressure, improves the LV systolic and diastolic function due to reverse LV geometric and interstitial remodeling, and down-regulates the beta receptor density. Now, these are the device. I think the earlier device was, this was the earlier device, Rihas baroreflex system. You have the pacemaker implanted here. There are two electrodes, one to the right side and one to the left side, and using this system. But it was more bulky system. I think this is the new system, which is device is implanted again here, and the new carotid sinus nerve stimulator. The device carries one electrode only rather than two, and this electrode which will be fixed to the carotid sinus nerve. So I think this is smaller in device, has a better battery life. I think lasts for about 3 years or so. And these are the two trials which have been presented at the European Heart Meeting recently. One was the Anthem heart failure trial. That's autonomic regulation therapy by either left or right vagus nerve stimulation in patient with reduced ejection fraction. 60 patient optimal pharmacological therapy they were on, left stimulation 31, right and 29, 6-month follow-up, and LVF showed improvement by 4.5%, and systolic volume improved by 4.1 cc, LVN improved by, I think, minus 1.7. The clinical improvement was seen in 77% of patients. The chronic low amplitude ART while autonomic regulation therapy while left or right sided vagal nerve stimulation is feasible and well tolerated in heart failure with reduced ejection fraction patients. Safety assessment do not raise concern. Efficacy measures are encouraging and warrant further study. Another trial was also presented in the same meeting, that is Nectar heart failure trial, randomized sham control trial, effect of vagal nerve stimulation on cardiac remodeling, cardiac function and exercise capacity in symptomatic heart failure patient with severe LV systolic dysfunction, despite guideline recommended optimum medical therapy. They were randomized to 2:1 ratio to receive therapy, vagal nerve stimulation on and vagal nerve stimulation off for a 6-month period. 87 patients, primary endpoint was LV asystolicity. There's no change, and I think other parameters are also like LV ejection fraction, P oxygen consumption, NT-proBNP failed to show superiority compared to sham treatment. Significant improvement in quality of life and NVHA class in the therapy group was certainly seen. So they tried to conclude the vagal nerve stimulation failed to demonstrate a significant effect on primary and secondary endpoints, measures of cardiac remodeling and functional capacity in symptomatic heart failure patients. So I think at the moment, though theoretically, logically looks that the vagal stimulation should help the heart, but I think these two trials, but I think we need more data and more evaluation to really see how this kind of therapy matures into our clinical practice. Now there are the two ways that you can stimulate vagal stimulation, but they are also not much used. But these are the, I think, technical possibilities. One is cervical vagal nerve stimulation, and effect cardiac parasympathetic change comprise. So I mean, it's you stimulate the vagal nerve in the cervical region, and this is done by putting a electrode to that, and like again implantation of pacemaker. P and to post-ganglionic parasympathetic efferent transmission seems to be impaired during cardiac failure. Electrical pre-ganglionic cervical vagal nerve stimulation may be useful to establish the diminished cardiac vagal tone in patients with heart failure. This has its an antiarrhythmic effect. It increases vagal refractory period, but there is also a concern because vagal nerve stimulation sometimes may also result in atrial fibrillation, and that's known effect of a high vagal tone. And rate slowing effects, negative chronotropic and dromotropic effects, anti-fibrotic effects, anti-inflammatory effects, reverse remodeling. So these, I mean, some of the mechanism looks interesting, but this is cervical vagal nerve stimulator. And again, I mean, this is implanted. This is a patient with ICD, and this is also implanted. This is the electrode, which is screwed onto the, or it is like this was the CardioFit multicenter trial, 32 patient, class 2 to 4, low ejection fraction, right vagal nerve stimulation, 26 had serious side effects. Other 2 patients died because of the procedure, but there's significant improvement in which class, quality of life, and LV sort of ejection fraction and the volumes. This is the ongoing, which is going, this is the Innovate Heart Failure Study, Prospective, 650 patients, I think less than 40 ejection fraction, and which class 3, despite optimal medical therapy, follow-up in 5 years, primary safety endpoints, freedom from procedure-related and system-related events, primary efficacy endpoint, composite, all-cause mortality, unplanned heart failure. I mean, so this we'll see what are the sort of comes out of this study. This is another modality, that's intracardiac AV nodal vagal stimulation. I think we know that I mean, in some of the centers, his bundle pacing is also being done. So I think it is now possible that you can screw the lead to these areas and try to this. If you screw the lead to this area where is a rich vagal innervation, I think this is probably the basis behind this particular approach. Atrial fibrillation seen in 30 to 40% patients with heart failure. Rapid ventricular rates lead to deterioration. Inappropriate shocks in 5% of ICD patients. So the post-ganglionic fiber which supply AV node located in inferior right ganglionated plexus at posto-inferior anterior septum, and IRGP is located at apical surface of heart between ostium of coronary sinus entrance of IVC. So they can be targeted through the endocardium by screwing the lead, as I mentioned, into the lower part of the intra-atrial septum. There are prospective multicenter studies ongoing. I mean, short-term AV node vagal stimulation, patient already on CRTD, to investigate whether device can further. So I think these are the few modalities, I think, which using electrical means, we are being attempted that increasing the vagal tone, how it will then translate into the clinical benefit. So whatever the observation are available today, I think none of them has shown any, I mean, there's no promising evidence today, but I think these are interesting modalities, and maybe intractable heart failure patient where therapies, other therapies are not helpful, these modalities may sort of come and may try to help us to help these patients. Thank you so much for your patience hearing.
Thank you, Professor Talwar. The topic is open for discussion. Okay.
I'm going to ask you a naive question because this is not. We do quite a lot of biotelemetry work in our laboratory and looking at ECG, power spectral analysis, high frequency, low frequency analysis to get to sympathovagal balance. And we do that in particular in diabetic and control animal models. And I've always wondered about how you could do something about that. And I noticed that your electrodes from the pacemaker were extending upwards into the carotid to the baroreceptor region.
Yeah.
And I'm just wondering, at the end of the day, what you actually want to do is you need to feed back to the pacemaker information about the homeostatic control of the person. In other words, the blood pressure. You need to actually have a sensor device that measures blood pressure from moment to moment and feeds back to the pacemaker, which in turn can regulate heart rate. I mean, is that in essence what those electrodes are doing? Could those artificial bioreceptor systems be placed elsewhere in the body, let's say in the aorta, in the chambers of the heart, or something else? Or maybe I've got the wrong end of the stick, sorry.
No, as far as the last part you said that they may be placed in the electrodes in the heart. The nodal vagal stimulation is in the heart. That's why because you have the vagal fiber there, so that is there. But question is here it is only that the vagal centers, I mean the ambiguous cells in the brainstem, unless they are silent, say, unless there is stimulation reflexes going from the baroreceptor to that, then it stimulates, and from there then the sympathetic activity is inhibited and the vagal activity is enhanced. So it is only, these are the ways, I mean that how you can increase vagal activity to the heart, because that may be beneficial. So whether you do by baroreceptor stimulation, whether you do by vagal nerve direct stimulation, or you even go into the heart where there are vagal fibers, you in sort of screw a lead and then try to do it. So I think these are the ways of probably enhancing vagal activity of the heart to gain its benefit that I think we know.
But is this essentially an on-off system? In other words, you either stimulate or you don't, or can it offer moment-by-moment changes in heart rhythm depending on the blood pressure? So for example, if I'm sitting here or if I'm running to my car, can it actually change the activity of the pacemaker to increase heart rate or reduce it? Or is it a fixed, basically on-off stimulation system? Do you see what I mean? Can it be modulated electronically?
I think it should be, but I may not be able to. So I have no practical experience of using this device. So I'm sure that because at the moment it's mainly that different frequency also stimulate different, but I think if you have an implanted device, when your heart blood pressure change should be able to, or heart rate change should be able to affect the set of reflexes from that baroreceptors.
You can understand what I'm saying. There can be pathophysiology there, as in heart failure, but there could also be the normal physiology when we rest, when we run. And an ideal device would address both those situations, would it not?
Maybe, well, I'm sorry, I will not be.
Okay, so we have another question.
Good morning. Thank you very much for nice presentation and going through the physiology and pathophysiology of the sympathetic and parasympathetic. My question is on the sympathetic stimulation. In our university here in United Arab Emirates University, we do research on different types of shock. Do you think these devices or stimulation of the sympathetic ganglion could improve the hypotension that most of the patients with, for example, anaphylactic shock, they die from? Do you think that could be used, or what do you think?
I think you have to decrease the sympathetic activity rather than stimulate the sympathetic ganglion. Because as far as, if you have to blunt the sympathetic influence to decrease the sympathetic activity, so the blood pressure is for the benefit of blood pressure, rather benefit which may get. You see, like we know in sympathetic storms, patients with tachyarrhythmias, and sometimes they come in storms, and even patients who are on ICD may not be helped. Sympathetic denervation, that you cervical sympathetic, we remove that particular area, and it may help the patients. So if I get you correctly, it's not sympathetic stimulation will not help to lower the blood pressure. It may be rather on the opposite.
Yeah, along this way, do you think renal denervation could play a role in heart failure patients?
You see, indirectly, this is also these devices also affect the renal denervation. The renal denervation, whatever evidence we have today as far as the hypertension, it has not shown. The recent Medtronic study did not show that renal denervation will help. Though there are criticism to that study that probably, there are some limitation in that, but I think it's difficult to sort of answer this question. We have no data on that issue.
I ask that because I think there are some groups that are taking a look into it.
Yeah.
And maybe in the future we'll have something regarding this. Well, thank you very much.
Thank you.